one is going to be on pediatric surgical congenital anomalies. So it's going to be presented by Dr. Preconference. He is an obstetrician and gynecologist who has done his specialty on fetal maternal medicine. So it will be moderated by our colleagues, Dr. Gesam from my university, and Dr. Diop. They are both pediatric surgeons and assistant professors of pediatric surgery. So I will leave the session moderated. Start the session. Thank you.
Right. Good morning again. My name is Dr. Diop, as already said, Dr. Preconference, assistant professor in obstetrics and gynecology and fetal-maternal subspecialty, fetal-maternal medicine subspecialty. So he's going to present on prenatal diagnosis. As you all know, for the past 2 decades, it has been considered that the fetus is considered as part of pediatric surgery. But there are congenital anomalies that are present during your age or not, that are diagnosed at the gestational age of from 18 to 20 weeks. It is considered part of pediatric surgery, and Western setups actually fetal therapies are also being done. Recently, in Addis Ababa University and also other places, fetal maternal subspecialty has been placed. That's what Traveler wants me to discuss, and I hope we'll have a fruitful discussion afterwards. Give the floor.
Right. Thank you very much. Thank you for the nice introduction. So I have two maternal fetal medicine people in this hall also. So during the discussion, I think they are going to participate and have, I think, a good session this morning. So that is the topic of today's presentation, is prenatal diagnosis of common congenital anomalies. So this time I'm going to take you back to where the life begins. So we are going to discuss about the intrauterine environment, because this is kind of spectrum for us. It's like we are managing patients, but babies are in utero, and then we send it back here. So maybe this creates a platform where we can have a multidisciplinary approach, where we can have a multidisciplinary team, and so on. So I will go through, yes. So the idea of the fetus as an entity, as a person that's different from a pregnant woman, with conditions that are amenable to medical intervention and treatment, is that we fairly recent. Like in modern world, it was in 1980s and so on that maternal fetal medicine was established. And here with us, maybe it is 3 years, 4 years old child. So now we are going to see what we have achieved, and then what are maybe the common pediatric surgical fetuses that we have, and what are the benefits of the prenatal diagnosis. So prenatal diagnosis, basically, apart from identifying the abnormality, these are the most important things. These 4 questions should be answered. What are these? The first one is, which anomalies may require pre or postnatal intervention? Okay, this has to be answered. Prenatal diagnosis. Where should the birth take place? Shall it be in a setup where you have pediatric cardiologist? In a setup where you don't have a pediatric surgeon? Where do you need neonatal ICU? And everything. So the setup during the transition from in utero environment to our world has to be well engaged. So this is one question that we need to answer. The other is how should the baby vaginal say, or shall we allow cesarean section? If that during delivery can it rupture, and then shall we be safe, and so on. These are the things that we answer during our evaluation of a fetus. And the other is, what is the prognosis? But this is the most difficult question. No, this is very difficult for us. No, so you know that it is not common to send a pregnant woman to you guys. Like it's better to ask the pediatric surgeons because we don't know exact prognosis of such conditions, like, for example, duodenal atresia, esophageal atresia. So that is the most difficult thing that we're having in our clinic. So what are the diagnostic modalities? So before we go to the diagnostic modalities, in fact, we go through 4 screening methods. We have soft markers, we have tests like quad tests, and so on. These are non-invasive tests. So if something shows up, like if that's when prior risk is higher, echocardiography and MRI. These are the above 2 are routinely done in our setup. The MRI, it needs kind of a good mind of image. Some private setups, you have MRI machines that can also be scanning of fetuses. So ultrasound is basically, we can talk about the anatomic scan. We do scan first trimester, it's delivered, but usually the structural scan is done at around 18 to 20 weeks. So if the woman is high risk, so important, for example, if you have complex type of cloacal chronic villi, then do karyotyping, microarray, and so on. Okay, then so the laboratory is owned, so they cost like 5,000 per sample too. We take also blood from the fetal cord, so it's usually done 22 to 24 weeks of gestation, and then there is include sampling. In developed nations, because these are invasive, and then there is a risk of like 1 in 200 to 1 in 600 risk of miscarriage. So what they do is they take blood from the mother, then they identify pre-fetal DNA or fetal genetic makeup that are skipped into the maternal circulation, and then that was very expensive. So for those who can afford, take us, sample can be taken from the mother, and then, but it's very expensive. So based on what's known about the anomaly from our scanning, parent species, and then the accuracy of the diagnostic modalities and so on, we counsel the patients. This is, as I told you, the most tough part of because as maternal fetal medicine specialist, the bad news breaker are either the obstetrician or the maternal fetal medicine specialist. So it's kind of spectrum. So we have to, I think, in the spectrum, we have to complete the spectrum by having an antidisciplinary team. So these are the fetal interventions, common fetal interventions. Like I can say fairly, we do most of the procedures. This, the open repair, so on, they need fetus, they call it fetal surgeon, but usually the background of that surgeon is a pediatric surgeon. So, if someone is tested, well trained, we will give you access to the womb, the intrauterine cavity, and then we will be the most invasive open repairs. So I have selected kind of 10 common congenital anomalies that are commonly seen in our maternal fetal medicine center. So let's start with abdominal wall defects. So what do we do? I'm not going to discuss about details, but I'll tell you how do we diagnose, what are the pathognomonic features during our evaluation, and then what do we do during our follow-up during antenatal. start with the gastroschisis. So this is gastroschisis. You can see the intra abdominal cavity content has escaped out of the cavity, the abdominal cavity, alongside of them. Not so the umbilical stump is intact. So the prevalence is 2.5 in 10,000. Most of the prevalences are that I have brought are from the developed nations, but I believe these are high. We don't identify most of the congenital anomalies. So these are the prevalence. Adverse diagnostic sensitivity of ultrasound is very high. It's nearly 100%. And we identify gastroschisis. There is no association. So we don't do invasive like amniocentesis and so on, karyotyping, a microarray, because it's not as such associated with any other. So the prenatal diagnosis of gastroschisis is based on identifying intestine-free floating in the amniotic fluid. So as you can see in the picture, there is the bowel loops that are free. There is no any membrane that is covering the intestinal loops. So this is diagnosis of gastroschisis. So we can also identify the gap in the skin of the baby. To identify the defect in the abdominal cavity. And then, because it's not passing through the stump, there is no blood flow. Others are not passing through the defect. So that's how we diagnose. So after we diagnose gastroschisis, okay, so we do gross anatomic scan, and the other is about prognosticating them. So this is the bowel loop. So in this bowel loop, you have bowel dilatation. This is the intra-abdominal segment of the bowel loop. So it measured like 2 centimeters for this case. She came and inserted that in the pregnancy. So it was like 2 centimeters. So what did we do? Just waited for until she started. She delivered. She actually delivered by cesarean section, and then she was sent back to you guys. So the baby required resection in that process, and the baby is still alive. The other is omphalocele. This is the other abdominal defect. So omphalocele is like is the association. We have association compared with gastroschisis. This is where you have the major difference. Trisomy 13, trisomy 18, 21, different cardiac anomalies, so it's also part of different syndromes. So if we identify omphalocele, that is indication for doing genetic tests. So the typical feature is you have a sac containing the abdominal cavity contents like the bowel and the liver, with the umbilical cord is part of the part that is. So this is the picture. So you have a mid sac. This is the baby. This is how the baby is lying. So you can see the protrusion of the abdomen. The echo texture looks like the liver is going out. Then, so you see these umbilical veins are also part of the hernia. It's a cross section. In this cross section view, this is the abdomen, and then you have anteriorly protruding the mass through the defect, and then you have a thin layer. That is part of omphalocele, those covered by the period. This is common to see ascites in the sac. That's also very good sign that we can diagnose omphalocele. So sometimes omphalocele, the defects can extend upwards. You can see such type of baby, for example, the heart is out of the chest cavity, or you can have the cloacal malformation. So what do we do? So we do detailed ultrasound examination, including echocardiography, because it is highly associated with diabetes. And then we also do invasive testing because trisomies are common in pelvis having omphalocele. The prognosis, for all patients, we give prognosis for those who have isolated abnormalities. Most of our patients with associated abnormalities like Down syndrome, trisomy, and so on, we tell them that the prognosis will be very poor. So usually such patients have pregnancies, but at the end of the day, it will be the decision of the mother. But for isolated small moderate exophthalmos, the literature says the survival is very high, and for giant survival is nearly 80%. But I think this can be reached also in our setup. If you have proper planning or management of cases since the intrauterine environment. And if you are prepared, the anesthesiologist, the pediatrics, the pediatric surgeon, if you can have kind of a multidisciplinary team, this is where I think we can achieve a good result. So the third anomaly that I brought is congenital diaphragmatic hernia. This is also a common finding for us. It's like 1 in 200, 500 live births, left commonly. So it's also associated, just like omphalocele, trisomies are common, then other genetic syndromes are also common in congenital diaphragmatic hernia. So this is a picture that I brought you. This is a woman who came in early third trimester pregnancy. This is the chest. This is the chest of the woman. So the primary feature of the diaphragmatic hernia is abdominal viscera herniated into the thorax through a defect in the diaphragm with associated deviation of the heart from its normal position. So as you can see here, this is the heart. You can see, so we measure the angle that the heart makes along the chest circumference. So see the line crossing midway, that's crossing the vertebra to the system, to the sternum, and then the line that is drawn along the septum of the heart, nearly they make 90 degrees. So the normal is 45 plus or minus 20 degrees. This is abnormal. So what happened there? So see, if you go in and see the echo, the texture of the picture, these are the lengths. These are kind of hyper compared with that of the liver. So the liver has popped up through the defect into the chest. So the heart should shift and then change the axis. So this is the other picture. The most sensitive way of diagnosing diaphragmatic hernia is if you see the coronal section of the chest, then you see the right lung and the left lung. So this is abnormal. This is a normal one. This is abnormal because the left lung and the right lung should be placed along the line. The liver, in this case, has pushed the right lung upwards. So look how liver is competing the heart in occupying the space in the chest. So what do we do in such cases? Usually, because the intrathoracic pressure would be very high, so the blood flow towards the heart cannot be reduced, and then you can have triangle restriction and so on. The management, what we do during the antepartum period is, so there's the liver in the heart. We try to check whether the blood flow through the ductus venosus is adequately going towards the heart. So what do? We do the ductus venosus Doppler velocimetry. So these are the spectral flows of the A wave. Atrial contraction occurs. It is a positive flow, so that means blood is adequately flowing towards the heart. So basically, the prognosis of diaphragmatic hernia depends on how the lungs are doing. The lungs development especially the canalicular phase of the lung development, need the amniotic fluid, needs a space. But in such cases, you know, this is the heart, I mean, the lungs development will be highly affected. So this is what we do. Okay, this is the lung. So we calculate the surface area of the lung and we compare it with that of the hair circumference. So we stratify it like as mild, moderate, or severe type of congenital diaphragmatic hernia. Then we tell the woman about the prognosis. Some of them terminate the pregnancy, and then some of them, based on the prognosis, they push their pregnancy. So this is another intervention that we're lacking. This should have been done. This is a fetal intervention. It's called a fetal, where fetoscopic endoluminal tracheal. This is fetoscopic endoluminal tracheal occlusion. This involves, you know, endotracheal insertion of an inflatable balloon in the trachea, so that, you know, the secretion of the lung is not, you know, vomited out, and then stays there. So it helps for the lung expansion in the canalicular phase lung development. The prognosis depends on, you know, how the lungs are doing. Are the lungs, you know, are they hypoplastic? So then the survival is very low. And then for milder ones, that is. So what we do with congenital diaphragmatic hernia is we try to check the severity and then take the woman up. For that patient that I have evaluated, she could afford, so she went to Italy for a fetal. And the baby is still alive. I think this is one thing that we can bring to our practices. So the other is surgical conscious leading to airway compromise. So this is a general thing. So commonly this is called aggregate, macrognathia, or teratoma, cervical teratoma, and list. So we believe cervical teratoma is one condition that pediatric surgeon should be involved in the management, maybe cervical, so that cervical of the baby can be guaranteed. Cervical teratoma, the prevalence is 1 in 50,000 births. It looks rare, but in our fetal center, this is one of the common causes, because, you know, it's easily to identify the neck mass, and then they usually send the patients to us. So we see maybe 5 patients so per year. So there is the incidence of chromosomal defects and genetic syndromes is not increased. This is then one good thing. So ultrasound finding is vascular solid mass with cystic components located anterior or antilateral to the. So an example. This is amniotic fluid. See, this patient presented with polar hypertension. She came to our clinic for screening of for targeted scan. So this was the outline. So you can see the stomach shadow is absent or very small. So this is what you got. The head and then the abdomen, okay, in the same plane. Tells you that, you know, that you have hyperextension. It's hyperextension. This is the baby. It's the head, and then you have the vertebrae. So I think this baby, the baby looks like this one. Can you see the anterior neck mass? So this anterior neck mass is more or less having a solid component. This is the close-up view, solid component, then with cystic spaces. So in such cases, we try to check whether you see the mandible is involved. That's the most important for such patients. So it's vascularized. Since this is a heart, okay, then the neck veins, we can see that there are some vascularization of the tumor. So this is what you can do. This is the cross section of the face down just below the base of the skull. So you can see the tooth buds Okay, no infiltration by the mass. You can see the throat. Okay, this is fluid filled. Most probably, if the mass is down there, including the movement of swallowing, and so on. So this is okay. So what happened to this patient? As we saw this patient in Gandhi Memorial Hospital, we sent the patient to Blackline Hospital for possible exit procedure. So unfortunately, the labor started at night and it was delivered. Intubation was very difficult, so we couldn't salvage this baby. So what do we do in our unit? So we do detailed ultrasound examination and follow-up scans every 2 to 3 weeks to monitor growth of the tumor, heart function, and mid-cerebral artery, systolic and amniotic fluid volume. And then the fetal interventions that we have, I think that we can do in cesarean section with exit procedure. You do have the capacity of doing surgeries on small babies. So this is what happens. While the umbilical vessels blood flow is intact, we then see the baby is getting blood supply from the placenta transfusion, so the surgery can take out only the head of the baby, then try to intubate it. If intubation is difficult, then what they do is they come to take the mass out, or they do tracheostomy. So this is also one, I think, important place where we can work together. The prognosis with a very big masses like that we saw, the prognosis is very bad. So neonatal death, about 80% of the cases. The fifth congenital anomaly that I brought to you is congenital cystic lung lesions. This, the most common one is, of course, congenital adenomatoid malformation, sequestration, lower emphysema, and bronchogenic cystis. Those cystis can be also recently the pathology after you guys did the surgery came up with the enteric cyst. So we can have a lot of the cystis, okay, in the chest cavity. So let me, because we have cases of bronchogenic cystis compared with others, so the prevalence is rare, but we do see like 5 to 10 patients having the chest cyst. That is manageable. So the prenatal diagnosis of cyst is very important because depending on the size, it can increase the intrathoracic pressure, can compress the heart, it can cause heart drops, and then even death. So this is one picture. This is a woman she's 26 years old, she's referred from with malformation. So she's referred from Adama. This is the chest. Then you can see the bronchogenic cyst. This is the left side of the chest. So on the left side of the chest, you have the bronchogenic cyst. The bronchogenic cyst has pushed the heart and pushed it towards the right side. So the heart has shifted from the left to the right side. This is the sagittal section. You can see the stomach, how small the stomach is, and then you have the cyst in the left side of the chest. This is a coronal section. You can see that it also crosses the midline. This is the picture. Okay, in a coronal section. You can see how the cyst is competing with the heart wall, the chest cavity. So this anatomic scan of the heart, sweeping movement, showing you now the heart is doing well. So what did we do? So we gave the baby iron relaxant, then the cyst was percutaneously aspirated. The cyst again reacclimated at 32 weeks, and then aspiration was repeated. and serial ultrasound showed no subsequent reaccumulation. So we did also, in such patients, we do also genetic tests. Genetic test was non-revealing. So this was after the procedure. You can see the left lung is well expanded. So this is what, why do we aspirate, bronchogenic cystis? Just to let lung expand and develop. Okay, so that the heart is not common, the intrathoracic pressure is not increased, and then the hydrops is not developing. So that for baby delivered at term, no respiratory distress, CT confirms the cyst, and so at the time of just 3 days prior to delivery, we did the aspiration. So this woman, during the evaluation, the chest was found to be normal. So we sent her to Blackline for the pediatric surgery department. Sure. So the baby was sent back, but the baby developed pneumonia, recurrent pneumonia, and then came back again. So by that time, the cyst was expanded, performance opened, the cyst was excised. But there are a lot of cysts that are excised within 1 week, 2 weeks. So this was one of our cases. So the baby has survived, and the baby is still living. So this is the other is solid teratomas. They are very dangerous. The sacrococcygenic, oral, cervical, and epignatic teratomas. They need close monitoring with us with weekly ultrasound because they can undergo rapid growth and result in hydrops from high output cardiac failure, or it may bleed into the amniotic fluid or into the cavity, the sacrum. So this is one of our case. So this is a tumor. You can see the sacrum in the corner. So the tumor seems it's arising around the sacrum. This is the tumor. So you can see this is the mass too. The vascularized bed, the mass. So that's why they can easily bleed. The upper ones are the umbilical arteries, and then this is the bladder of the baby. So at one point in time, it bled, and then the cyst expanded. It's very big cyst. So she came with hydrops. This is the skull of the baby, and then you can see the fluid collecting under the skin, skull edema. Then this is hydrops. You can see the heart is impaired. That's cardiomegaly. So the middle cerebral artery, which we use routinely for measuring the velocity, so that can tell us for whether anemia is present for the patient or not. Because as the viscosity of the blood decreases, the velocity increases. So this velocity is too high. So it shows us that the baby was anemic. So this is because this is baby is anemic. We have to transfuse the baby intrauterine. The abdomen of the baby. The placenta was unfortunately posterior. Anterior placentas are very easy to transfuse. Posterior placenta is posterior. We cannot access the vein. So what we do is we use the intrahepatic portion of the umbilical vein to transfuse. So you can see this is the needle tip. The white dot is the needle tip. This is the umbilical vein. You can see blood flowing across the umbilical vein to the baby. So anemia was corrected. Then after delivery, it was sent to the pediatric surgical unit. All right, let's take this small bowel obstruction. This is one of the common things that we get. So we have the incidence is 1 in 5,000 births. The incidence of chromosomal abnormalities and genetic syndrome is not increased with small bowel obstruction. So usually what we do is, in such cases, we diagnose and then we observe. So diagnosis is by presence of multiple fluid loops of the bowel, the abdomen. So for small intestine, 7 millimeters above is dilated. Usually this dilation occurs after 25 weeks of gestation. So in earlier gestations, you may not identify a bowel obstruction. No, during anatomic scan, you may miss the presence of small bowel obstruction. So with small bowel obstruction, what do? We do repeated ultrasound scan, like every 2 to 3 weeks. We do ultrasound scan, and then we monitor the growth of the baby. Then the only we do is, because such babies, they vomit now and then, they will have polyhydramnios, so we do therapeutic amnion reduction for such babies. So the prognosis is largely related to the gestational age, how much we can push the pregnancy, because polyhydramnios causes preterm labor, and then we have to reduce it again and again. And so those are being in preterm delivery, they will not have good outcome, but being term 1 through 12 is fairly good. That's the esophageal atresia. The prevalence is 1 in 5,000. It's highly associated with chromosomal defects. In 30% of the cases, you can see that such cases are other defects like cardiac, renal, vertebral are also found in 10 to 20%. This is a double bubble sign. The double bubble sign. So this, see, these are the 2 bubbles. One is the cup, the organ, the other is the stomach. So they usually have this polyhydramnios after 24 hours of gestation. So this is another picture. You can see the dilated stomach, and then also the duodenum. This double bubble sign. So if you see a fluid other than the stomach shadow, where you do the abdominal circumference, things should be that some kind of abnormality, right? So that is a double sign. So what do we do? Oh, the same thing that we do. We do ultrasound scan frequently, and then we try to make sure that polyhydramnios is not severe enough to result in preterm labor. So the prognosis is good if you can push the pregnancy to term in the result. The other common abnormality is esophageal atresia. So this is common, but diagnosis is a bit difficult for this case. So the incidence is 1 in 3,000. So we have associated with chromosomal abnormality. The most common sign is during scanning, after 25 weeks of gestation, you don't have a very small stomach, or you don't have any stomach shadow. So but the thing is, as esophageal atresia is highly associated with fistula, tracheoesophageal fistula, so fluid secretions can pass through the fistula and then give you a normal stomach. So this diagnosis of tracheoesophageal fistula is a bit difficult. It's like usually we have severe polyhydramnios and so on. We send patients for evaluation to neonatal ICU, evaluation of tracheoesophageal fistula and so on. So this is what happens. So the classical is you can have a pouch, okay, because it's a blind loop. So if you are lucky, you can see fluid regurgitating out of the mouth of the baby and so on. So what do we do? The same thing. We make sure that polyhydramnios is not causing preterm labor, so we reduce fluid. Coming to the kidneys, I can say the most common abnormality are multicystic kidney and hydronephrosis. So multicystic kidney is the prevalence is 1 in 1,000 versus it is associated with chromosomal abnormality, but not as such, especially the unilateral one. We have a lot of patients and they usually start. So this is what happens. The kidney is replaced by multiple irregular cysts of variable size. See, this is the normal kidney, and this is the abnormal. The right one is normal. You can see multiple cysts. Okay, renal pelvis cannot be identified. So how do we differentiate from hydronephrosis? With hydronephrosis, the cysts are communicating, then you can also identify the renal veins. But here, there is no urine production, there is no pelvis, and the cysts are not communicating to one another. So this is a close-up picture. See the cyst also. Sometimes the cyst can be too big, right? So, compressing the contralaterally, then compressing the bowel. Then so, in such cases, we drain the cyst. Then such patients are also referred to a pediatric surgeon for evaluation. And then if the cyst is growing, expanding, nephron can be done. But usually, what we have in our patients is, the cyst is decreasing in size, and then sometimes it's difficult to identify them at the age of 2 and 3 years of age. So the prognosis for unilateral is just like normal prognosis. As far as it is isolated. So coming to urethral obstruction can be, that's also one common finding that we get. Usually it is urethral stricture or posterior urethral bulbs in the male. It's common in the male, and then the prevalence is 1 in 1,500. It is associated with chromosomal abnormalities, so such patients also need genetic tests. And so there are different type of modalities of staging the hydronephrosis. So we usually use the Society of Bacteriology staging method, but you can compare them with the other systems. So that's how we follow them. So I'm going to give you one patient of ours came with, you can see severe oligohydramnios. The head is, the shape of the head is kind of dolichocephaly, and then you have the club feet. Then you can see the bladder very much distended. So the wall of the bladder is thickened, and presence of trabeculations. So this is the key that we have. It looks like it's rarely that you have such type of kidneys. So the cortex is having cysts, ring of cysts. That is completely gone. This kidney is no more functional. Also, this stage 4. So what do we do when we have such obstructions? We do detailed ultrasound examinations because it's associated with other structural abnormalities, and then we do antenatal evaluation of renal function. How do we do it? We take sample from the bladder and then send it for electrolytes, so sodium, calcium, either you have a cutoff limit, and then we check whether the kidneys are functioning or not. So the other is amplitude volume is measured. So if everything is, if the baby is babies can survive, we push the pregnancy and then send this baby also to you guys. So the prognosis is to be severe. So I have completed the 5. The 10, congenital anomalies. So this is the time now to discuss about the role of the multidisciplinary team. As you have seen, after the life has begun, then you have a spectrum of diseases, changing across the gestational age, and then but most of the cases that we saw today are pediatric. We need pediatric surgical assessment. So after 1980s, where fetal medicine has started, it has been also the job of the pediatric surgeon. Okay, so the fetus has been included as your potential patient also. So I think this is a good platform to have kind of a multidisciplinary in those places where you have pediatric surgery or we have fetal medicine specialist. So the decision elsewhere regarding antenatal follow-up, the timing, place, mode of delivery, as well as procedure to be performed is starts in utero. So pediatric medicine experts, pediatric surgeons, pediatric specialists, clinical geneticists, transfusion medical specialists, genetic counselor, midwife, and social workers are the members of such multidisciplinary team. So they meet every 2 weeks and so on. So to decide on the pregnancy. So I think this guy is a pediatric surgeon for his scrub clothes. Thanks.
Thank you very much for a very nice presentation. Really, it's a very eye-opening, and I think it's going to be a new field. Maybe some interested young surgeons are going to be fetal surgeons in the future. And I will open now the floor for further discussion questions. I have one question for you until you decide on what to ask. You were talking about pediatric surgeons being involved in exit surgery. And really, we appreciate the early diagnosis so that there is a timely management as from a maternal fetal specialist, because even an early management, an early surgery brings a significant improvement for our patients' management. But with regards to an exit procedure, what do you think are milestones that must be reached generally from the medical field, from our service to start such kind of procedures? And this is going to be my question, and I will open the floor for further questions. Maybe shall we initially take some questions so that you will respond? You can answer. If you have any question. So you can.
Yeah. I think based on the experience that you guys, I have seen exit procedure in one of the Western setup. And so, for you guys, based on the experience that you have, and that's a very easy job. And then it is something that we can do like in the near future. For large masses, just accessing the trachea and then going out safely, maybe enough. That's what. But most masses are usually small masses, but still resulting in like securing the airway. We usually try with the anesthetist to secure the airway, but it usually fails. And that is a problem. And then I think based on for your experience, that's a very easy job, I can say.
Besides the pediatric surgeons, it's going to be a multidisciplinary team. So I was thinking about anesthesia, also about development of the MDTs, then the ICU. So maybe if you could comment on that.
Yes, definitely. Yeah, as I said, multidisciplinary team, okay, including the neonatal ICU, anesthetist, pediatric surgeon, pediatricians, then maternal medicine specialists, the midwives, even social workers. Everything should be involved in the management of such patients.
Thank you. So, a lot of session for today. Just to add up what there's already raised. Now we are good in somehow we are good in human resource. We do have pediatrics anesthesia with the speaker of pediatric surgery with our specialists. So when should be the time to start out, at least with the basics of intervention as exit or as intervention with a short period of time, anything, what should be the entry point analysis program and how can we start and what can we establish?
Yeah, I think that is the main question, and that is a question that is not going to be answered by oneself. This is a very good point for discussion, and then but for me, I think this is the time when we should start that establishing that team, because there are a lot of cases that we really need you to be involved. Maybe while you are during your clinical practice, it's not uncommon to to see a pregnant woman coming to you and then asking you whether the baby is going to survive or not. You know what? We are sending that patient to you guys. So what should happen is, because such patients should get the ultimate answer, not like she shouldn't go around the city and so I think this is the time, because I think this is the time that we need to start. So maybe I have Dr. Kasala and then Dr. Said also. They can also add.
Thank you. Thank you so much. Nice discussion. I'd like also to congratulate the organizers having this kind of discussion. I have one question. It's practical actually. Two questions actually. One is how do you manage the mother's emotional status, like when you tell them they have a abnormal child, because we've seen mothers with this abnormal child who are diagnosed and pregnancy come to us and some of the business. And the reaction is very bad. Actually, all the family are very much depressed. So, then anything other than those like to manage this psychological status. The other thing is what is the role of people are most normal which are not compatible with life, making the decision. Bad type of determinants. Other determinants which are also which are not compatible with life, making a decision, because we don't have this kind of multidisciplinary approach. Counseling with mothers, whether as a permanent or continuing pregnancy. So, what is your experience? How do you see this?
That's a very good question, and then that is the most challenging part that we're having. So, I said we are usually the breaker of the bad news. Then know how to break the bad news. It's been difficult since I have joined the maternal fetal medicine, because they usually come for a normal follow-up and so on, and then have this pathology. So the thing is, it's like ethics is one of the course that we take during the attachment. We follow the principle of ethics during counseling a woman. So we follow all the steps of ethics to counsel the woman, but still telling the prognosis for a woman is a bit difficult. Regarding termination of pregnancy, so if identify a later congenital anomaly, we tell them that that's a later congenital anomaly. And then, but the woman is the one who can choose whether the pregnancy has to be terminated or not. So there are some women who want to keep the pregnancy, until labor and delivery, but until 26 to 20 weeks of gestation, she has the right to have a termination of pregnancy. After 28 weeks of gestation, termination of pregnancy is going to result in premature children, pain, induction, and then now the surgery, inflation, and so on. So And for those who arrive to us after 20 weeks of gestation with lethal congenital anomaly, we advise them to push the pregnancy until labor. That's what we do. Regarding lethality, usually the difficulty for us is numbers. The way numbers are interpreted in our society is a bit different. So you tell them like your baby is having single characteristic because you don't have normal, you have everything is normal, no soft markers and so on. Do any genetic test based on your priorities, your age is okay, but the word that you give for this woman is too much. So usually they want to do genetic tests and so on. So that is the difficulties that we are having. A small information, minor information for them. This picture is a very big one, and then sometimes you tell them that's it's a little that's a little congenital anomaly, but there is a 2% chance of them surviving the age of this and this, but 2% for our pregnant women in 2 weeks. So that is one difficulty that we have. Otherwise, we follow all the ethical steps and then the principle of ethics.
Thank you so much for the nice presentation. I really appreciate just the topic, and I believe this is a very good time to establish our multidisciplinary at the end of the public and meeting. So I expect to have a multidisciplinary team, which we have a platform for the national pediatric surgeons and all other stakeholders, involved in some platform so that we can update each other. That's my expectation. Thank you so much. I will have some specific question on the effect. Once you diagnose abdominal defect, the cases of RPC, you have special protocol to follow these patients with some serial ultrasounds and to decide the timing of delivery and also the mode of delivery, like measure the intra-abdominal dilatation of the bowel and also the extra-abdominal dilatation of the bowel, because the extra-abdominal dilatation might tell you that the defect is narrowing and it's going to be a closing type of gastroschisis, which are the risk of ischemia. So we have such kind of protocol. Yes, we don't have. All right. And the other thing is bronchodiolysis. There's aspiration might help grow the lung and so on. And like this patient has got diagnosed after patient developed with recurrent pneumonia. But basically, aspiration might, for some time, it might improve, but definitely the word is impacting this kind of patients would have recurrent and would have been linked from the beginning, because you need to have some image control, chest X-ray or CT scan postnatal. So, like you have such kind of things until you manage patients in postnatal follow-up and communication having but some sort of communication, which is focused communication, as pediatric surgeons or just. May I ask others if you have any additional questions so that we can summarize?
Maybe it's also a question. I see nowadays teaching subject, especially CTH. Sorry, friends, decision. Most of the time, the problem we have is not an outcome scans a delayed diagnosis. So if it was diagnosed earlier, not earlier, maybe we might save something for patients. So most of the time I see almost everywhere. Symptoms. People are doing this obstetric scan. The problem is everybody is focusing on the head circumference and also measuring the gestational age. Nobody is interested to look around the other things. Maybe I think you people who are coming to the picture, you are focusing on that. I think it's better to give some kind of such kind of training for your colleagues, obstetricians, because I see that usually passing by side and so gestational rate and other. So at least the basics. If you don't see the stomach, it means this. If the patient is having polyarthritis, you have to do a total scan. Total scan. How to do such kind of scan is done. So I think these things should continue this trend for us, for the whole obstetricians, and also people obstetric care. And I think there are good ones which are
still have some noise about this version. Ones that we have made. I
think the thank you very much. I think this is
Okay.
thank you.
Really very nice questions. Dr. Oki's question, I think, is also about abdominal wall. So, what we do with anterior wall defect is usually its own part. It's a big one, and those cases, we, as much as possible, we advise the woman to have cesarean section very well. But usually, women having gastroschisis and then such severe defects, they don't consent for cesarean section. So usually, vaginal delivery would be the. But for those who can consent for cesarean section, we usually prefer cesarean section delivery because we, as much as possible, we want everything to be intact and sterile. He refers those patients to neonatal ICU. About that case was maybe one of the cases that we had managed earlier. It is not, I think, a good example. We had a lot of cases from that one where we just linked them within maybe the first week, the cyst has been taken out. So these are the patients. So about hydronephrosis, what do we do with hydronephrosis? So when a patient comes with, during early gestation, during anatomic scan, we measure anterior posterior, the renal pelvis diameter. So at around second trimester, it is greater than 4 millimeter, and then that is concerning for us. So we usually follow them, whether it develops to hydronephrosis or whether it resolves. Usually, in 90% of the cases, it resolves. So for those having hydronephrosis, we check, we just check the amniotic fluid volume, the bladder volume, whether the bladder fills on and so on. And sometimes if you have complete obstruction, you also take a sample from the bladder and then check whether the kidneys are functioning or not. So at the time when we think the baby is viable and then our neonatal ICU is capable of not taking care of the baby much enough, the baby can survive, so delivery will be planned. But we usually link such patients to neonatal ICU. I think that is the gap that can be identified. So nearly most of our patients are sent to neonatal ICU, gastrocysts to neonatal ICU, to neonatal ICU, everything to neonatal ICU. I think that is a gap that has to be addressed. So that can be refined through discussions. So about the breaking the results and news for a pregnant woman, that, like, from our experience, we are the one, because we do the scan and then they usually ask you. So you just tell them what is the problem, prognosis. But what's recommended is to have the team. So to have a team, like ATEX team, to have a team which is like capable of managing the patient. So after talking thoroughly about the case and then advise the patient about the prognosis, that is what's advanced. But now such link is lacking, such network is lacking. So we are the one that are. Thank you.
So we have some sort of
Guidelines. No, yes, we just follow the ethical guidelines. We discuss about the patient. Then, okay, we don't have a separate room. Discuss about the case. So we tell them.
Just to follow up on this question, maybe the post of prognosis of these patients is not going to be textbook. Our prognosis may be not similar to that of the textbook prognosis. So I think the main worry would be if you tell a mother that the prognosis is going to be such and such, but the setup that you have as pediatric surgeons may be a bit different. So what will be wouldn't it be a challenge? I think, as you said, the MDT would solve it. But I think that will be one. Yeah.
Counseling. There's no one outside programs. Data and money. And we don't have any data. Surgical outcome depends. Surgical conditions. Usually, that's hospital. All specialists are at the advanced stage. Have been national guidelines. And this is not the only area that have issues with the conditions. Most common. That's very much counseling, outcomes, patients with similar to the need to have this similarly. Yeah. That conditions. It's very counseling. should be. We now just concurrent approach. Strong.
There's one question that's missing.
It's not a question, actually, just as Dr. Gisham said, the textbooks in our experience, for example, when you see the outcome of gastroscopy on pharmacy, we do have also study in our center document. And the textbooks, like it says, on pharmacy has more than, gastroscopy has more than 90% survivors. And on pharmacy has 40 to 50%, especially associated with that's the reverse in our center. It's a very good debate, I suggest. And as it has been said, I think the decision sometimes, individual decision and decision is, I think, has a different impact. And I think we have to strengthen that perspective in that very good solution. Because we do have also experience, there are obstetricians who terminate severe hyperplasia, who terminate gastroscopy. So I think there should be such kind of team, and in the future, we all work to create awareness and so on. Because the obstetricians also should concept the trade of so yes, a big practice, something to be trained. And actually, also WHO also has standard. It's recommends of structural assessment that it should be used, yes, but it's not. I'm not mistaken. That's not a practice in our country. There should be such kind of mechanism to also increase prenatal infections.
Thank you, Dr. Kamil. And we go to the next question, but before that, I think also from pediatric surgical staff as well, we need to create research so that our outcome is more African based, and you can use research. One thing that I think is very important is what is the practice of teaching or informing the obstetricians, your friends, with regards to this genital associated anomalies, because they might miss that was especially if you have any additional analysis.
Okay, all right. So that has been a challenge for us all, but now people are getting aware. Then when they identify something, they are sending back to our clinics, to my clinic. And then otherwise, no, the way as an obstetrician, having anatomic scan it needs a little bit extra training to have a normal anatomic scan. But there are some markers that can be identified by sonographer, by the midwives, general practitioners, and so on. They identify those markers. They are advising them to send back that.
Yeah, if the teaching was like doing a physical examination, when they are doing the ultrasound, just they come just like somebody doing a physical examination. And in my personal experience, somewhere, I was an obstetrician. I was doing this obstetric scan because I was a pediatric surgeon. I was doing a kind of physical examination. I tried to look around and the obstetric, but I go through the vertebra, just I focus on the stomach, focus on the bladder, not any. If the patient is having that means something. It's a signal. Something is wrong there. So I have to further focus on that, not only circumference, not only femoral veins or what, not only on the muscle. Such kind of things has to be emphasized during the training, that they have to learn to do such kind of verification during their ultrasound, also the gestational age, and also
That's really good.
Maybe financing.
I'm taking you back to my first question. I agree with you, but just make decision and continue to the pregnancy. But you know, in some countries like in Cambodia, practice euthanasia or member marriage already born children. Like if you see a mother is pregnant with anencefalo, you advise them is still to wait her decision like to continue this pregnancy, or what I'm trying to say is there any congenital anomalies which you can advise the mother to terminate the pregnancy. Sometimes they terminate the pregnancy early, like some places, so that they put the babies in. Then, because they think the uterine cavity better for problems come, so they grow the baby outside. So, in your experience or in your common sense, are there anything in this condition which you advise? Sometimes you see the biggest picture of if the mother wants to have a child with meningomyelin, who was not able at the end of the day control both bladder and violent bladder control, well as not able to walk, and So I just want to hear from you.
Yeah.
Just to avoid also what the PSA that institutions make their own decision, either to permit or not. So I'm trying to have a committee of group of people who can make this decision, because it will be, because as a doctor, you don't play the role of God. You don't say this man should die, this one should stay. So I leave that for another person to make the decision. But we decide, having a committee may be very important for what do you think about that?
Yeah. So in our case, for specific congenital anomaly, we will have it's like we generally know the outcome. For example, as you mentioned about if you have baby having hydrocephalus, so we check whether it is severe hydrocephalus or mild or moderate, and then we also check whether there is associated anomaly. We do also genetic test for those who can afford. So if it is isolated, mild or moderate hydrocephalus, we tell them that the outcomes compare severe hydrocephalus. So the hydrocephalus is progressing or associated with like neural tube defect and so on. So we advise them that this is you're going to have a poor outcome. In fact, we do have a study of the past 5 years of those patients that came to us for prenatal screening, then identified with neural tube defects. Then for example, the 1 year survival rate is 11%. It's associated with highly compromised lifestyle, like incontinence, then the paralyzed and so. So such things we do have. For those, we have the data. We tell them about the problems. Usually, for neural defects, we see and so on, they usually go for termination. But there are some of our clients, because of religious reason, they tend to continue. See, then we follow such patients, taking the blood pressure, and so we follow them until the onset of pregnancy. So the survival is for each case, we advise them based on the data that we are having. But we tell them so that they are involved in the decision. Because studies show that if the woman is not involved in the decision making, and then after termination, most patients they develop psychiatric conditions, depression. So, in nearly always, we inform the patient respecting her autonomy. As what I said, it differs from case to case.
Thank you very much, Doctor. It was a very nice session. Thank you for the lively questions and answers time with our professors and our doctors. So I hope, as Dr. Orkier said, maybe the society or the obstetrics gynecology society, the Preconference team would some kind of organized kind of meeting in the future. Hope to see that. Our session for the morning is finished. Thank you. Let's congratulate you.
Thank you. Presenters and moderators and the audience for lively session. So we have short